Good afternoon. I would like to introduce my PhD topic, which is about conservative therapeutic possibilities for extra and intra-articular temporomandibular disorders. My name is Kata Kelemen, and I'm from the Department of Prosthodontics. My vision is to establish a TMD protocol that is available for all patients apart from the localization of the dental offices. My mission is to make an emphasis on the prevention and also on the therapy as well, and to have a proper funding to increase the level of evidence. My specific goals are: the first one is to investigate the conservative therapeutic possibilities for myogenic temporomandibular disorders, and the second one is to investigate the conservative therapeutic possibilities for temporomandibular osteoarthritis. My first topic is investigating the efficacy of additional splint therapy to physiotherapy in adults who have myogenic temporomandibular disorders. While the temporomandibular disorder is the third most common stomatological disorder, and the 10th or the 15% of the population has this kind of disorder. The most common type is the myogenic type, and in its therapy we can use the occlusal splint therapy or the physiotherapy as well. The unmet need of this study is to find the pain relieving method. So my aim is to investigate which reversible and conservative therapy offers the best results in decreasing the TMD symptomology as well, so we can increase the mouth opening and we can decrease the pain. My clinical question is there a difference in efficacy of additional occlusal splint therapy to physiotherapy in adults who have myogenic temporomandibular disorders? The P would be adults with local myalgia. The intervention would be additional splint therapy to physiotherapy, manual exercise, education and counseling as well. And the comparator would be physiotherapy, manual exercise and counseling. The primary outcome would be the range of motion that can be measured in millimeter with a caliper, and also the pain perception that can be measured on a visual analog scale. The secondary outcome would be the improvement in quality of life. My hypothesis is that additional occlusal splint therapy is more efficient. The clinical implication is that we can improve the TMD symptomology and we can improve the quality of life of these patients as well, so we can decrease the pain and we can increase the movements. I have done the systematic research in the following databases, and after the study selections, I have found 9 eligible full tags that can be used for the statistic analysis. And here you can see my results for the first outcome, that would be the pain perception and the 4-week follow-up. At the first graph, you can see that the heterogeneity was quite big, and we have an outlier of the articles that was the last article, so we redone the whole analysis, and the heterogeneity does decrease, but still the results shows that there was no significant difference in the control and also in the intervention as well. And the second outcome would be the mouth opening. Here you can see the 4-week follow-up results. And at the beginning, there was a significant difference in the physiotherapy. And after we were removing the previous articles, and this heterogeneity or this significance just vanished. The research implication is we would like to facilitate more investigations on splint and placebo therapy, and also on pharmacotherapy and splint therapy as well. The research limitation is that there was only a few articles that were available, and also there was a heterogeneity in the population. My second topic is investigating the efficacy of platelet-rich plasma over hyaluronic acid, steroid and ringer solution injection for TMG osteoarthritis. While the 8th or the 16% of the population has this kind of disorder, and in its therapy we can use the arthrocentesis and lavage, which can be an intermediate place between the surgical and the conservative therapeutic possibilities. It can be conducted under local anesthesia, and we have many medical devices that can be used. And the unmet need for this research is to find a pain-relieving method. My aim is to investigate the efficacy of PRP over HE, steroid, and ringer solution as well. So my question is there a difference in efficacy of PRP over HE, steroid, and ringer solution in the treatment of TMJ osteoarthritis? My hypothesis is that PRP is more efficient than HE, steroid, and ringer solution. So the P would be adults with TMJ osteoarthritis. And I would like to make a network meta-analysis. So the first intervention would be the lavage with PRP, the second one would be the hyaluronic acid, the third one would be the steroids, and the comparator would be the ringer solutions. So the first primary outcome would be the range of motion, especially the maximum mouth opening, that can be measured with the caliper. And also the secondary would be the pain perception, and we can also measure some side effects and negative outcomes. While the clinical implication is to enhance symptoms relief, we can use with the PRP an autogene medical device. I have done the preliminary research on these databases, and here you can see the connections and also the network of my full text selections. I have found 27 texts that were eligible for my network meta-analysis. So here you can see an overview of my two meta-analyses, and I would like to finish them till July. And I would like to finish my lecture with a quote: "If the plan does not work, change the strategy, but never the goal." And thank you so much for your attention.
What's the meaning of two lines? Because normally you would expect, that just one. So you have 2 and 1 between the hyaluronic acid and steroid. So what's the difference between the 2 and the 1?
The purple, the one is that shows an article, so the lines are articles. So I have found one articles that can compare the hyaluronic acid and the steroid, and the 2 refers to 2 articles that have the PRP, HE, and the steroid as well.
I have seen this a couple of times, but now I just realized that I don't understand. Thank you.
My only question is is there any heterogeneity in the type of hyaluronic acid that was used in the trials, because the polymerization rate of this compound can be different. Do we know what is the exact molecule size that was used?
Yes, I have already read these 27 full texts, and I have found some heterogeneity because, for example, some cases they were using low molecular weight or high molecular weight hyaluronic acid, so that can be, yes, an increase in the heterogeneity.